Thank you. Good morning, ladies and gentlemen. It is my great pleasure to welcome you to the 10th Complex PCI 2025. Over the past decade, Complex PCI has grown steadily thanks to your continuous support and participation. I would like to express my sincere gratitude to everyone who has walked this journey together. For this 10th edition, we have prepared an exciting, meaningful program for all participants. First, you will see 13 live cases from the 6 reading centers in Korea, China, Japan, sharing the advanced techniques in real time. There will also be 50 inspiring lectures delivered by the global experts covering key topics such as the main bifurcation imaging, high-risk PCI CTO, and many more. Last but not least, we've got a very special session at the end of the day, the TCT 2025 hot issues. Here, you can catch up with a summary of the latest research outcomes presented at the TCT last month. I believe this year's program will offer valuable insight for daily practice and help provide better care for our patients. Hope all of you enjoy Complex PCI 2025. Thank you.
Thank you very much, Dr. Park. I'm Antonio Colombo from Milan, Italy, and it's a great pleasure for me to introduce the first lecture from Dr. S.J. Park, left main and multivessel disease, revascularization, guideline-based real-world practice in Assam Medical Center. Thank you.
Thank you, Antonio. Really, I want to briefly review about new guideline-based real-world practice in our hospitals. Everybody knows that ultimate lesion for revascularization to improve symptoms, to improve survival. That is clear. Revascularization for multivessel disease, lots of study. Look at this, medical treatment versus bypass surgery or PCI. Recent data and old data is almost 40 years distance. And PCI versus CABG, recent data, almost the last 20 years, syntax best Fahim 3 studies in this year. Look at this. What is game changers? I think, look at this, we analyzed our data, ischemia, best 10 years, and Fahim 3 5 years data. What has changed is actually physiology and imaging supported PCI. That is totally different one. And so look at this. This is relatively old data and new data. Medical treatment versus bypass surgery or PCI. This is the first randomized study, the CAS trial, you know that. They included 2 to 3 vessels, 73%. However, excluded less than 35% of ejection fraction, low ejection fraction. Actually, no difference at all between the medical versus surgery. If you look at the subgroup analysis in the low ejection fraction, 3 vessel group would be better, not statistical significance. Bypass surgery would be better for low ejection fraction, less than 50%, and 3 vessel disease subset. Very important study, Stitch trial, medical versus bypass surgery. They included, 1,000 more than, mainly ischemic cardiomyopathy, less than 35% ejection fraction, and they included 2 to 3 vessel disease. 5-year data, not statistical difference. However, 10 years data, all deaths is clearly different. That is the reason why bypass surgery would be beneficial over the medication. Right, less than 35% ejection fraction in terms of ischemic cardiomyopathy. Medical treatment versus PCI, very limited data. However, 2015 coverage, 15 years data, clearly no difference between the two. medical treatment versus surgery or PCI. There's only data, very 2D study, diabetic patients, maybe 67% at 2 to 3 vessel. Low risk group, actually no difference in terms of survival and MACE rate. However, in diabetic high risk, bypass surgery may be better. However, no survival benefit even in the surgery. These data, difficult to apply the old data to current practice. Old study used the bare metal stent, and even for centers and jolting stents, all the studies include the Cypher in Texas, lack of concept of FFR and imaging. So, medical treatment versus bypass surgery for the multivessel disease, I think ischemia study, is a cutting edge. Ischemia study included the concept of FFR and ILUMIEN intervention. You know that CCTA, 50%, moderate to severe ischemia, they randomized with conservative treatment and invasive treatment, more than 76% of multivessel disease. Look at this, angiographically, more than 80% included vessel diameter is more than 2.25. Patient not recommended less than 80% and negative FFR. They recommended the FFR for the, prove the ischemic concern, intravascular ultrasound, minimum luminant area. They, anyway, included the concept of physiology and IVC imaging. Primary outcome in 3 years, actually no difference at all. Conservative and all deaths, no difference. Microinfarction, no difference. Any subgroup analysis, including the ischemic severity, diabetic, and anatomic severity, presence of proximity, no difference at all. Even in the diabetics and non-diabetic, no difference in terms of conservative and invasive treatment. Extended 7-year, all deaths, no difference. So, medical treatment versus bypass surgery or PCI, actually no survival benefit of invasive strategy. Optimal medical treatment is good enough. Bypass surgery has survival benefit for low ejection fraction. Would it be beneficial for diabetics? However, we don't need enough data about that one. So, PCI versus bypass concern, not too much data. Actually, for the diabetic patient, freedom at 5 years in terms of bypass surgery is clearly better. Syntax subset, 3-vessel subset study, 10 years data. Mortality is better in bypass surgery. Meta-analysis, all deaths, bypass surgery is better. In case of, especially for the diabetic and multivessel disease, bypass surgery better than the PCI. It's clear. All the data clearly demonstrate a higher mortality in PCI group rather than bypass surgery. So if you look at mortality difference, actually just starting to disappear with the emergence of the new concept of physiology and IVC PCI. That is our first data. Best 10 years, actually PCI versus bypass surgery, all deaths, absolutely no statistical difference. There's no mortality difference. The only data start with a no mortality difference between the PCI versus surgery in multivessel disease. We use the second generation of the rolling stent, everolimus rolling stent, and IVUS arm, PCI arm, almost 90-80% we use the IVUS optimization after we imaging guided PCI actually started in the best trial. All right, Fahim 3-5 years, you know that. All-comer FFR-guided PCI presented in TCT meeting. Primary endpoint, death stroke MI, absolutely no difference. Landmark analysis is no difference at all. If you get to compare with the syntax study, the image-guided PCI, actually definitely different outcome. Death stroke MI, no difference between the PCI versus surgery. However, in syntax is totally different. Hard endpoint death, no different at all. Fahim 3 study at 5 years data. Death stroke on MI, actually no statistical difference in terms of death stroke MI clinical endpoint. What does it mean? So we have some concept of physiology and imaging concern. No difference in primary endpoint based on the syntax score. It means angiographic anatomic complexity is not always matched with physiology. In other words, angiographic anatomic complexity is not always matched with clinical ischemia. So summary holder data, we are changing now. Contemporary PCI incorporated both FFR and imaging guidance can make a better clinical outcome. We need more data for diabetic patient with a multivessel disease. And so we just, conducted defined DM study, 3-vessel diabetic patient, FFR, image-guided PCI, and standard bypass surgery. So, with the summary, big changes. Anyway, contemporary PCI incorporated both FFR imaging guided class 1A. We have to think about it, And if you look at the guideline, ACCH guidelines, goal of revascularization clear to improve symptom and to improve survival, main multivessel, low ejection fraction, bypass surgery recommended. Patient with diabetics, high risk anatomy, actually bypass surgery recommended. Low risk anatomy, why not PCI recommended. ESC guideline changed persistence angina, actually class 1A indication, improve outcome, normal ejection fraction more than 35%. Look at this, main was 3-vessel, normal ejection fraction, any revascularization. What does it mean? It's almost equipoise in terms of a PCI in bypass surgery, main and 3-vessel, normal ejection fraction, 1-vessel, 2-vessel. Any revascularization would be 1A, actually 1B. All right, and so hot discussion, low ejection fraction, that is another issue. Multivessel, low ejection fraction, bypass surgery recommended. However, high surgical risk is PCI recommended. Without diabetics, actually, in high complex anatomy is bypass surgery, low anatomy complexity is PCI. Diabetics, bypass surgery recommended. At high surgical group, PCI recommended. 2A concern. So, revascularization, PCI versus surgery, bypass surgery has survival benefit for high anatomic risk 3-vessel disease, low ejection fraction, less than 35%. However, diabetic patient, very limited data. So, freedom studies, very 2D study. So, real practice in our hospitals, low risk, any 2 to 3-vessel, multi-vessel, normal ejection fractions, why not? We're going to do the contemporary PCI. And high risk 3-vessel, low ejection fraction, unfavorable anatomy for PCI, bypass surgery, all right, recommended. But even in the high risk patient, not high surgical risk group is 1 or 2-vessel PCI with medical treatment. All right, main revascularization, briefly review that one, not much data. Totally different. Syntax 10 years, no mortality difference. Syntax 10 years, pre-combat 10 years, our data, no difference at all. Noble 5 years, no difference. Excel 5 years. Primary endpoint, no difference. Actually, hard endpoint concern is no difference at all. Meta-analysis is clear, same. All deaths, no statistical difference. All deaths, 10 years, no difference. Noble 10 years, just presented in the last TCT meeting. Look at this. 10 years, all deaths, no difference. Time-dependent landmark analysis, actually no difference at all. Even acute coronary syndrome, in case of acute coronary syndrome, PCI would be better. Mortality stratified for syntax score, actually no difference at all. So very interesting findings here. Mortality, PCI with or without final ILUMIEN, final ILUMIEN optimization group had is almost better, best outcomes. So what's the difference compared to the, multivessel disease? No mortality difference between the PCI, bypass surgery, and main disease, totally different. Multivessel, mortality difference, however, main disease, no difference at all. So, main disease, high complex coronary anatomy, bypass surgery, poor candidate surgery, PCI, and main disease, basically bypass surgery. However, syntax score low, intermediate syntax score low, anatomic complexity, look at this, PCI recommended, very, very improved in terms of a guideline concern. Main disease, cerebral, concomitant high risk anatomic complexity, low ejection fraction, survival, maybe benefit. So absolutely, main disease is not surgical disease anymore. And so we just started main trial. So we think main disease is not a surgical disease. And so we want to do FFR guided PCI and angio guided PCI. We're going to start our study. Simple lesion, favorable anatomy, PCI. Complex anatomy, low ejection fraction, why not? We recommended bypass surgery. However, in our practice, actually, less than 20%. Thank you. This is Ron.
Thank you very much. We have the discussion after next two presentations. So, Dr. Duk-Woo Park, diabetes mellitus and three-vessel disease, why we need a new randomized trial, define EM trial.
Thank you. Thank you, Antonio Colombo. So, and this is my disclosure. And everybody knows well the diabetic is absolutely global epidemic in the Asian country, in the Western country, absolutely in the world. We expected at least 20% diabetic patient increased over the next 10 years. So, and this is a typical example of a diabetic and three-vessel disease and a typical case of a defined DM trial. And the right coronary artery proximal RCA, distal RCA significant region, and the mid-LAD and the significant region, and the SOC is there are significant region. How do you feel after seeing this case? And contemporary guideline absolutely 100% recommended bypass surgery for this patient. But most interventional cardiologists feel that I can treat well than this patient. This is absolutely clinical dilemma. Although guideline recommended bypass surgery, and the most interventional cardiologists in the modern era think about we will treat this patient just stent 3 or 4. And so, and we have a different revascularization strategy in diabetic and multivessel disease. This is a really issue over the last 20 years, bypass surgery versus PCI. I just briefly showing all the evidence. This is a syntax trial, is a historical random trial. Over the 1,800 syntax study, just diabetic patients is 452. It's a very limited number of a population. Hard endpoint, no difference. Main difference was repeat revascularization. This is a VEST trial. It's a VEST trial published in the New England Journal of Medicine. Among the 800 patient diabetic subgroup, just 363 patients. There was also same finding, and the repeat revascularization was difference in diabetic population. And the contemporary guideline is based on the freedom and the VERITUDE trial. There was consistency 20 years. And the freedom trial and the Valentine Fuster was a PI. That was nearly initiated 20 years ago. And the bypass surgery was better in hard endpoint, the death MI stroke 5 year. Also, this is consistent up to 10 years. The VERITUDE trial, some different trial, there was some ischemia trial concept, and the low anatomical risk patients comparing PCI versus OMT, high anatomical risk, bypass surgery versus OMT, and the survival is no difference, and the freedom of a MACE, no difference, PCI versus medical therapy in diabetic patient. A relatively high risk patient, no difference bypass surgery and OMT survival, but bypass surgery was better reduction of the MI. So based on contemporary evidence, US and European country and fully recommended bypass surgery is class 1 recommendation, absolutely there was no rule, even relatively low anatomical risk of multivessel disease, there is no recommendation of the PCI. There was an absolutely big discrepancy in the contemporary guideline recommendation. And there are many limitations, and already old data is available, no use of contemporary DES, DCB, just the Saipan Texas era, and absolutely 0% use ILUMIEN or FFR, and the diabetic medication totally different. At the Freedom era, just metformin and sulfonylurea was mainly used. Nowadays, SGLT inhibitor, GLP-1 receptor agonist, class 1 recommendation in diabetic patient. So, and absolutely we require additional random trial because of a previous trial with too much old-fashioned in the era of a modern PCI world. And the contemporary state-of-art PCI, we are routinely use the FFR and the ILUMIEN, and there was a upgraded class 1 recommendation. And also diabetic medication is totally different based on a lot of huge random trial. SGLT inhibitor, GLP-1 receptor agonist is class 1 recommendation. There are a demonstration of the reduction of cardiovascular outcome. So, and that was the defined DM trial rationale. We believe we're gonna do state-of-art PCI physiology and imaging supported PCI with contemporary drug lowering stent. On the background of the advanced GDMT, we can achieve the comparable outcome to the bypass surgery. And the defined DM trial, in the finally, we will include the 1,500 patient diabetic 3-vessel disease, not involving left main disease, and the anatomically suitable PCI or bypass surgery. We do state-of-art PCI versus standard bypass surgery. And the hypothesis would be non-imperial trial. And the inclusion criteria is very simple: diabetic, type 2 diabetic, and the 3-vessel disease by angiographic diameter stenosis more than 50% would be suitable. And the exclusion criteria was a STEMI patient within 5 days, left main disease will be excluded, and the too much complex disease not suitable for PCI will be excluded, and the 2-vessel disease CTO will be excluded. 1 vessel is allowed. And the trial endpoint we will adapt hard clinical endpoint, the composite of all-cause death, MI, or stroke at 2 years. And the sample size estimation is based on Freedom trial. At 2 years, we assume the event rate 11% in bypass surgery group. This is a non-imperial trial. We adapt non-imperial margin was 1.38. This is identical to the Excel trial, adapting same primary endpoint. So, and the final sample size was 1,500 patients. And the state-of-art PCI, we are routinely use FFR and the imaging-guided PCI. Protocol specified the PCI will be performed in the Giants stand, and our trial absolutely requiring the solid funding, and the main funder is Abbott, and the overall trial funding surpassed absolutely $5 million. And the combined use of DES and the DCB is allowed. And the FFR, we do intermediate region, we will measure the Abbott coronary pressure wire, but the very tight region, more than 90%, that would be, can be deferred FFR the use, and we just treated only functional significant stenotic region, FFR less than 0.8. If you decide to the stand and we do imaging guided PCI for final optimization, we will follow EA-PCI expert consensus document. And the bypass surgery group, and if randomization, we will do bypass surgery within 30 days, and the RIMMA to LAD mandatory. Whenever technically feasible, complete revascularization is strongly recommended. And the anti-diabetic medication, so important, and we routinely use SGLT2 inhibitor or GLP-1 receptor agonist, and the general glycemic target is HbA1c less than 7.0%. And the primary endpoint, we will measure 2 year. Also, we will plan the 3 year and the 5 year follow-up. And the current status and overall, the 67 center in the world and the European country, Asian Pacific region, Australia, and now joining in our trial until today, we included 99 patients. So, and additional 20 center from France and Canada and Brazil, and recently decided to join in our trial. So absolutely any research interest in the participating DEFINE-DM trial, also you think about your center has a very comparative cardiac surgeon, and we always welcome your participation in DEFINE-DM trial. This is a truly international collaborative trial. And this is key finding. All the evidence suggested bypass surgery is class 1 recommendation, PCI class 2B or 3 recommendation, but there are several limitations and not out of dated is a clinical trial, and we believe state-of-art PCI with advanced GDMT can provide a different answer, and the newly launched DEFINE-DM trial will provide the compelling evidence, novel paradigm change of PCI role, alternative choice of DM revascularization. Thank you for your attention.
Thank you very much. The last presentation of this section is by Jung-Min Ahn from Hassan Medical Center. He will present unmet need for FFR in left main PCI, FATE main trial.
Thank you, Dr. Antonio Colombo. I'm Jung-Min Ahn. I will talk about our new trial, FATE main trial. This is the typical case, left main ostial lesion. Do you think is it a very tight stenosis, significant stenosis? Different views show that looks tight. Another view doesn't look tight. So, what is the significant stenosis of left main? Left very significant. The right is very normal, but there are lots of gradation. So, previously, every randomized trial, large randomized trial, pivotal trial, left main significance of left main was determined by angiographic stenosis. So previously, what is stenosis of left main more than 50% was considered as a significant left main disease. Yes, previously the left main bypass surgery versus medical treatment studies, more than 50% diameter stenosis surgery was associated with the better survival compared to medical treatment. Even if left main stenosis is more than 70%, the better survival by the surgical treatment, worse survival by the medical treatment. So according to the diameter stenosis severity, left main patient outcome could be stratified. In addition, the intermediate left main disease, compared with the no left main disease, the survival rate is a little bit worse. So, however, this is a ischemia trial compared with the no left main disease, intermediate left main disease associated with the higher the spontaneous MI rate. However, we already knew that angiograph analysis for the left main is very poor reproducibility. So we used ILUMIEN. Previously, minimal lumen area 7.5 considered the significant left main. Next, the 6 square millimeter, we consider the significant left main. The above the 6 square millimeter differ. Below the 6 square millimeter revascularization showed the similar clinical outcomes. Previously, we also defined the significant left main minimal lumen area was 4.5 to predict left main FFR. 0.80, accuracy is almost 80%. So ES guideline, the 3A, B, level B, ILUMIEN should be considered to assess the left main severity. So the 2024 ES guideline, left main PCI, we have to consider the intravascular ultrasound. But the intravascular ultrasound was not also perfect. The ILUMIEN or the intravascular ILUMIEN or OCT, the left main looks like this, the eccentric configuration. This is a typical case. Left and right. Right edge looks very tight. Left edge doesn't look tight, but FFR is different. FFR is 0.71 left, FFR is 0.89 right. Look inside. Left left main is a very diffuse disease, lumen is very small, but right is very eccentric stenosis, lumen is very large. So definitely we need FFR measurement to evaluate the significance of left main, but the left main is different from non-left main. Non-left main, reverse mismatch is very common, but for the left main stenosis, reverse mismatch is very common because left main is mild, looks mild, but the supplying myocardium is very large. Frequently FFR is below the 0.8. So we have to consider this concept. Then how about the deferred left main disease based on the FFR? Summarizing the previous data, deferral of left main disease by FFR looks very safe. Overall deaths per year 2.6, MACE is 8.2. Compared with the left main PCI data, deferral of left main looks safe. So Swedish Heart Registry recently showed that based on the FFR 0.80 over the 0.80, the long-term mortality looks fine, better than IVUS deferral groups. So however, we have to know that the technical issue of FFR measurement of left main disease, if there is just some ostial left main disease, to measure the FFR, we have to disengage the guiding catheter to avoid the guiding catheter bias. Guiding catheter if engage the tight ostial lesion, FFR should sometimes increase, sometimes decrease. So to avoid the artifact, we have to disengage the guiding catheter in case of left main ostial evaluation. In addition, bifurcation evaluation is very tricky. So every left main bifurcation, disease is continued from the LAD to left main or circumflex to the left main. So for the left main bifurcation evaluation, we usually recommend you the LAD pullback and both LCX pullback. But the LAD pullback is usually lower than circumflex pullback, and prognostically LAD is more important. So practically I measure the LAD FFR rather than circumflex FFR. But left main is frequently associated with the daughter vessel disease, LAD or circumflex. In such case, if we measure like this, FFR always show the negative FFR. If we measure like this, FFR could be the first positive left main FFR. Previously, Will Ferron nicely demonstrated that unless downstream stenosis is very significant, its impact is mild. So if FFR is more than 0.45 LAD FFR, the left main FFR, you can measure the circumflex FFR, you can consider the left main FFR. In addition, circumflex FFR is 0.85 or FFR value of left main is above the 0.80. In addition, we can use the tandem lesion concept. If there is just some left main FFR and LAD FFR, you can use the pressure wire pullback, and after treating the bigger delta pressure gradient and you measure the FFR, you can measure the exact left main FFR value. We previously published how to measure the left main FFR as an editorial. In addition, recent scientific statement by the Spiral Bangalore nicely summarized how to measure left main FFR. So this is a previous case. We measured FFR. FFR is 0.79. IVUS also showed a very tight left main disease. We implanted a stent to the left main to the LAD. So this is a kind of a fate main trial. It's just we enrolled 35% to the target population, 960. We enrolled 339 patients. So we believe that the fate main trial will determine how the FFR works in the treatment of left main PCI. Thank you for your attention.
Thank you very much, Dr. Ahn. We have time for discussion.
Okay, I have one open to questions, Antonio, and the many audience from Asian Pacific region, but this even in diabetic and the multi-vessel disease and three-vessel disease, and the contemporary guideline is fully recommended the bypass surgery is class 1, but many Asian interventional cardiologists still much prefer the PCI rather than bypass surgery. Main reason patients don't want to open the chest. But my question is, in Italy and another European country, how the patient or physician follow adherent to contemporary guideline is a bypass surgery is class 1.
But I still believe that in Europe, bypass surgery, especially for advanced center score, is still the major practice of revascularization. Of course, every time you ask the patient, naturally the patient prefers not to have the chest open, but if you discuss seriously, the data available are in favor of bypass surgery. I mean, Dr. Park gave a nice overview, except for some trials that are outlined, most of them are in favor of bypass surgery. I have a question about the DEFINE trial. IVUS guided, imaging guided is very important, we know. My concern, especially in diabetics who have diffuse disease frequently, is IVUS imaging guiding. Do we have the risk to overstent? Because we like the terminology from healthy to healthy, but in diabetics, the healthy part may be missing. So how do we plan to be, to avoid again the full metal jacket, the long stains, all the mistakes that we did in the syntax?
Yes, and Antonio, I think that is a very important technical question, and during our DEFINE DM initiating meeting in the many centers, it's the same question. Diffuse, usually diabetic has a diffuse lung disease from LAD ostium to the distal LAD. They are avoided to full metal jacket. So in our trial protocol, we allow the mixed use of drug-eluting stent and TCB. And you can treat up to mid portion from LAD ostium, put the metal stent. Distal part is allowed the use of concomitant TCB. So, and sometimes we do and put the stent in the 1 or 2 in the proximal middle part. Distal small vessel, we apply the TCB. And that is a common combination.
But even in the proximal LAD, if you do imaging, you see a lot of disease. And sometimes your tendency to implant a 38 millimeter stent in all proximal LAD. Is that correct? Or should I don't know, I'm not here to tell you that you should not, but I have some reservations because if you do 2 years follow-up, maybe everything is fine, but then if you go 5, 6 years, things may be different.
Actually, revascularization with the stent procedures, personally, I think we don't need a complete removal of ischemic burden, right? If just you mentioned about the diffuse disease, we have to decide the landing zone, proximal distal. However, very old, we have some data. There are some diseases, however, plaque burden, some part less than 35%, a little bit concentric one, I think it's okay, right? As even diffuse disease, you're gonna make a distal landing zone with a more physiologic, manner, and then adding some, obvious findings. And we don't believe too much about the full metal jacket in the previous concerns. However, the clinical outcome is not so bad. However, we have a more cautiously and combined with the drug-eluting balloon dose, DEB dose in some part of a distal soft disease.
Quick question, DW. In your trial, you said you're going to be using a lot of physiology. So is physiology going to direct the endpoint also? Like, okay, the physiology was abnormal, you stented, and then are you going to recheck physiology at the end? So is that part of the protocol?
Yeah, our DEFINE DM trial tried the contemporary state of art PCI, means widespread use of FFR and IVUS, and FFR is mainly used to treat or not treat. You know, it's a very tight lesion, more than 95%. You don't need FFR. It's some looks like intermediate lesion, and you check it out FFR. FFR is okay. It doesn't touch. It's just the medication. But FFR less than 0.8, you put the stent, and then IVUS. If you decide to put the stent, IVUS was used for final optimization. Okay. It's just the widest practical use. Yeah.
May I? So Duk-Woo is really interesting. So maybe not, maybe related to the previous questions. So you know, in diffuse vessel like diabetes, mostly you will have if you measure the PPG index, will be diffuse, right? So did you still measure this patient, doing PCI, and how do you define the successful of the PCI?
Yeah, so and the PPG index is now some booming. It's a diffuse disease. That means the differentiate the focal disease and the diffuse disease. But we don't routinely use the PPG index. It's just the FFR used the treat or not treat. And the IVUS optimization, that is okay. In the final, at the final stages, we don't routinely recommend the post-FFR measurement. Yes.
Dr. Jung-Min Ahn, in FATE Main, you're using FFR, but in many geographies, we're using non-hyperemia-mediated physiologic assessment. So do you think that FFR is interchangeable with other modalities, let's say with RFR or IFR?
Thank you very much. Very nice, very important questions. But first of all, the RFR and other non-hyperemic pressure ratio could be interchangeable. So the several small studies show that FFR guided deferred and IFR guided deferred show the favorable outcomes. But theoretically, I prefer for the left main, I prefer the FFR instead of IFR. So because non-left main disease, what we should find that non-left main disease, I think medical treatment is a default treatment strategy. So non-left main disease, IFR is enough, I think. But the left main disease, if we miss the left main disease, it would be associated with the patient critical outcomes. So we have to find the unveiling left main disease. So in this purpose, I think FFR is more important than the IFR or the non-hyperemic pressure ratios.
You know, in my experience, it's just several advantages, just practically speaking. It makes cases go faster so nurses don't have to pull the adenosine. Also, if you're given intravenously, it increases patient discomfort, so satisfaction goes down. And you have a relatively certain amount of period of time where you could get measurements. But with RFR, for example, what we use, we could take our time and get exact measurements, so there's no time pressure. But it seems like with left main disease, in your opinion, FFR is preferred compared to non-hyperemia-mediated physiologic assessment?
Yeah.
Okay.
Dr. Han, I have a question. I'm not clear about the design and primary hypothesis of FATE left main. Is it the non-inferiority testing or superiority testing of the FFR-guided left main PCI?
FFR-guided left main PCI is superior than the angio-guided PCI.
So, as you well know, FFR is not treatment modality, it is diagnostic modality. So you are mainly treating the PCI for all the angiographically significant stenosis versus selective treatment of left main PCI. So do you still believe FFR-guided left main PCI will be superior in contemporary era of the PCI for the left main?
Yes, the result of FATE main trial will answer to your question in 2 or 3 years later, so maybe. Yeah. So I fully agree with your opinion and your concern. So personally, I think for the complex disease entity, we need more the intravascular ultrasound or intercoronary imaging rather than physiology. So I fully agree with your concern, but the data is data, science is science. So let's see the result of the FATE main trial.
I have a question for the FATE main trial. If you have some lesions in the mid-LAD, would you treat the LAD lesion first and then evaluate the left main as part of the protocol?
Yeah, if the LAD disease has a bigger delta FFR compared with the left main, treat first the LAD and re-evaluate left main. So.
Right.
Yes, so far, if there is some total disease in the LAD and circumflex, so far we don't have any accurate measurement to evaluate left main disease alone. So the not 100 perfect accurate to evaluate left main, but I think after LAD treatment, left main evaluation is the not optimal, but anyway the best way to evaluate left main disease.
And sorry if I ask you so many technical questions. If you treat the left main towards the LAD, and you know at the baseline that the circumflex was not critical, but after treatment of the left main to the LAD, you have some compromise of the circumflex. Would you repeat the FFR on the circumflex to make a decision?
Actually, we don't have the largest studies, but we have only the small studies. Dr. Soo-Jin Kang's 10 years ago, she did one study after simple crossover stenting, even though the jailed side adventure of circumflex, FFR lower than 0.80, the incidence is only 7%. So baseline angiographically looks good circumflex, even after the simple crossover looks jailed. The FFR is instance of FFR functionally significant left main is very rare. So if we do something more, we recommend the circumflex FFR before do something more.
Thank you. All right. Thank you for discussion, a great discussion. We want to move to second session. Dr. Seung-Jun from Severance Hospital will give us imaging-guided provisional stenting for LM-PCI, insight from RENOVATE, OCCUPI, October, and ILUMIEN study 4.
Thank you for introduction. I am Seung-Jun Lee from Severance Hospital, Korea. This is my today's topic. I will more focus on the role of OCT guidance in the left main PCI from the recent pivotal trials. Based on the today's topic trials, the recent guideline has escalated both IVUS and OCT as a class 1A recommendation for the complex lesions and particularly for the left main stems. And for these changes, these 4 pivotal trials and along with the OPTIVUS trial has significantly contributed, except for the ILUMIEN 4, which excluded left main for their study population. All other 3 trials included left main as their complex lesion, and all trials utilized OCT fully or partly for intravascular imaging device. So the left main subgroup study from the RENOVATE showed significant benefit for reducing target phase failure with imaging guidance. And in this trial, we can observe the discrete preference of the provisional strategy in the trial. And similarly, in the left main subset of the OCCUPI trial, OCT guidance showed a marked reduction of the composite endpoint at 1 year. And similarly, in the October trial, which included 19% of the left main disease, there was a numerically lower occurrence of the adverse event at 2 years by the OCT guidance. So taking these pivotal trials together, we can clearly say that OCT guidance consistent benefit even in the left main PCI across pivotal trials, and these findings contributed to the change of the recent guideline. For the remaining times, I would more discuss about the actual current remaining issues and the further directions in the OCT and left main PCI. From the RENOVATE trial, if you see the fractural pattern, then we can show a strong preference of the IVUS over the OCT, 91% versus 6 to 7% preferring IVUS. Why IVUS preferred in left main PCI? We can assume that the greater penetration depth of the IVUS suitable for large caliber vessel and no need for contrast injection and well-established optimization criteria that provide operator confidence and comfortability in left main PCI. Whereas in the case of OCT, we can, during left main PCI, you can frequently encounter some hurdles like the difficulty in image acquisition and the risk of ostial obscuration or the unclear optimizing criteria. So for the interventionist young like me, so sometimes we can encounter this kind of very poor image in the large vessel like left main. So in this case, we always should go back to the basics, so ensure the coaxiality of the guiding catheter centrally located in the vessel lumen in the multiple projection view, and the adjustment of torque and forward and the backward movement of the catheter is quite essential for left main PCI. However, in case of the proximal left main disease or the aortic ostial disease, the use of OCT is quite troublesome. However, if we apply the guide extension catheter like the telescope or the guideliner, guidezilla, we can sometimes or partly or fully overcome this hurdle. As you can see here, if we the radio opaque part of the guiding catheter produced this typical intermittent shadow. However, if the OCT pullback device exceeds this part, we can acquire the very clear image of the left main. So we should precisely adjust the location of the extension catheter. And next concern is the issues related to contrast use. However, in the OPTIVUS and OCCUPI trial, there was evident increase of the contrast dye ranging from 50 to 100 milliliter. However, the incidence of contrast-induced nephropathy was not different compared to angio or IVUS guidance. So, if we use the OCT contemporary device, we can utilize the co-registration function, which can avoid unnecessary angiography, and we can fully utilize the OCT capability with this function and replace unnecessary angiography. So back to basics, so periproscial hydration and the limiting of the contrast volume based on patient eGFR is quite important. And recently, there has been advancement in the OCT device. JSKIM in our institution recently developed a new device with very quick imaging acquisition, 2 or 3 times faster, and AS-based imaging processing. With this benefit, we can obtain the image of the LAD within 1 second. This is the angiography view with just saline flushing without any contrast. With this approach, we can obtain the interpretable image. I think the development of device may further overcome the hurdle in OCT in the complex PCI. The final issue in the OCT guidance is left main, maybe the absence of the optimization criteria. So in case of IVUS guidance in left main, there has been very representative optimization marker provided by AMC and recently updated. However, in case of OCT, still there is no strict criteria. Recently, there has been the proposal by the European expert suggesting MSA values. However, this is just a suggestion based on expert consensus, not supported by the strong scientific evidence. Recently, very recently, last week, we have provided a postdoc paper for our OCCUPI trial analyzing each parameter derived from OCT on the clinical impact. We could observe that every parameter is strictly related with clinical outcomes, and the cutoff values, MSA 4.5, and the relative criteria was quite similar to that of our predefined or European consensus. However, even in our trial, there has been no strong MSA point dedicated for left main, meaning that we need more evidence supporting the OCT optimization criteria for left main PCI. So, summarizing today's topics, the clinical benefit of imaging guidance, particularly OCT guidance, is unequivocally evident in left main lesion, and these findings has led to the change in recent guidelines. However, although technical hurdle of OCT image acquisition still remain in left main lesion compared with IVUS, I think these challenges will increasingly be overcome through advance in the operator skill expertise and the advancement of devices. Finally, dedicated optimization criteria is absolutely required for OCT guidance in left main PCI. Thank you for your attention.
Okay, thank you very much. We continue with the next lecture. Yoshinobu Murasato from Japan, imaging guided left main PCI. Hiroki Shiomi, OPTIVUS complex PCI left main cohort, a large scale prospective IVUS guided left main PCI registry in Japan.
Thank you for the introduction. I would like to talk about the one-year result of left main cohort of the OPTIVUS complex PCI, large-scale prospective IVUS-guided PCI registry in Japan. As you know, recent randomized trials clearly demonstrated the benefit of IVUS over angio-guided PCI in reducing cardiovascular events after PCI. However, if we look at data on IVUS on clinical outcome in Japan, where the IVUS-guided imaging PCI has already widely spread as a usual care, we couldn't confirm the clear benefit of IVUS over angio-guided PCI, although it was registry data. So simply using IVUS may not be equivalent to IVUS-guided PCI targeting optimal stent expansion. So we conducted a prospective multi-center single-arm registry where PCI operator performed the IVUS-guided PCI targeting predefined optimal expansion criteria. This study consisted of the multi-vessel cohort and left main cohort, and today I show the result of the left main cohort. The key exclusion criteria included ST elevation MI and cardiogenic shock. We set 5, 6, 7, 8 rules from Korea as optimal IVUS criteria. We also recommended sophisticated PCI-related treatment, including radial approach, newer generation drug-eluting stent, and a shorter duration of dual antiplatelet therapy to improve clinical outcome. From 2019 to 2023, we enrolled 902 patients who underwent IVUS-guided PCI with stenting in left main region. Because this was a single-arm study, we set performance goals based on the event rate of PCI and bypass surgery for left main disease in historical Japanese cohort. And the hypothesis of this study was that the OPTIVUS outcome was superior to the historical cohort of PCI predefined performance goal for the primary endpoint of MACE at 1 year. Now we achieved the one-year clinical follow-up in 99% of the patients. Baseline characteristics reflected the typical Japanese PCI population. Mean age of the patient was 73 years old, and half of the patient had diabetes mellitus. For region and procedure characteristics, we performed FFR or resting index in about 30% of the patient. Radial access was 72%. Left main and three vessel disease included 24%. High syntax score 11%. If we look at the Medina classification, true bifurcation of 111 included about 15%. About half of the patient had 110. Two stenting was only performed in 5.7%. While we used the cutting or squaring balloon in 40%, kissing balloon technique was only 60% in this registry. How did the IVUS evaluation change PCI strategy? For the pre-intervention, first IVUS evaluation changed the PCI strategy in about half of the cases if we look at the questionnaire from the PCI operator, including the performing more aggressive lesion preparation using cutting balloon or atherectomy device and using the larger balloon and stent size. For post-stenting intervention also changes the PCI strategy in half of the cases. Most of that was aggressive additional post-dilatation. This slide shows one of the key findings of this study. As you can see, the rate of meeting IBUS expansion criteria was achieved in about 85% of the patient in each segment, while the cases achieving criteria in all segments was 73.7%. The clinical outcome of this registry is pretty good. The MACE rate at 1 year was 13.2%, which was much lower than predefined PCI performance goals and numerically lower than performance goals for bypass surgery. The stent thrombosis was occur only 1 case, and the rate of TLR at 1 year was only 4.2%. This slide shows the clinical outcome between patient meeting or not meeting the IBUS expansion criteria. Although there was no significant difference between the primary endpoint of MACE between the 2 groups, but TLR rate was significantly lower in patient meeting IBUS expansion criteria. Next topic is the difference between on-site and core lab analysis in the IBUS image. Actually, as you can see, the measurement between the on-site and core lab were generally correlated, but there was about a 10% disagreement in each segment. And in these cases, the TLR rate was about a 2-fold higher in case with agreement. And furthermore, in cases where the quality of IBUS was poor and couldn't be assessed in core lab, also showed a higher TLR rate, indicating the importance of acquisition of clear IBUS image and precise interruption during PCI in clinical practice. The other message from this study was the importance of setting goals during PCI in IBUS-guided PCI. We performed IBUS core lab analysis in left main case in a historical PCI cohort, although it is a limited number of the patients. However, the result clearly showed that the OPTIVUS cohort targeting optimal stent expansion criteria improved the achievement of the optimal result by 10% in each segment. So finally, this is a formal conclusion of this study. Thank you so much for your attention.
Okay, Honorable. Next talk, Dr. Murasato will give us imaging-guided LM-PCI long-term outcomes in acute coronary syndrome versus non-ACS patient, please.
Thank you, Chairperson. My topic is the imaging-guided LM-PCI long-term outcomes in ACS versus non-ACS patient. This is my disclosure. This is a British nationwide survey to investigate the impact of the intracoronary imaging in various complex PCI. Here you can see in the left main PCI, intracoronary imaging significantly reduced MSCC rate and mortality more than 50%. And this is also a Swedish nationwide survey. Here you can see the imaging-guided left PCI reduce the primary endpoint, especially mortality. However, this slide shows the intracoronary guidance in the LM-PCI in the nationwide registry data, and there were no significant. This nationwide survey did not provide the sufficient intracoronary imaging guidance around 30 to 40%, especially low in the severe left main ACS state, such as STEMI. So, despite the guideline recommendations, the benefit of the routine use of intracoronary imaging in all left main coronary intervention cases remain unclear. This study evaluated the long-term clinical outcome, the routine intracoronary imaging-guided left main PCI in a real-world cohort, including the high-risk acute coronary syndrome patients. The study is the multi-center retrospective observational registry study. A total of 806 consecutive patients who underwent PCI for unprotected de novo left main lesion with drug-related stent implantation in 19 Japanese hospitals. Study period 2016 to 2020. Of the enrolled patient, out of criteria, incomplete follow-up at 3 years, and indefinite definite for ACS or non-ACS, these patients were excluded, and this cohort finally divided the two groups: 561 patients without ACS and 241 patients with ACS. Primary endpoint is the major adverse cardiovascular and cerebrovascular events, MSCE, defined as a composite endpoint the following at 3-year follow-up: all-cause death, cerebrovascular disorder, clinical-driven revascularization, and myocardial infarction. Secondary endpoint the risk factors of 3-year MSCE. In terms of patient background, the ACS group had less treatment for the hypertension and dyslipidemia, and the ACS group had fewer presence of the peripheral artery disease, prior myocardial infarction, and prior PCI or failed CABG. ACS group had lower left ventricular ejection fraction. And in terms of laboratory, the ACS group had higher level of the total cholesterol and LDL cholesterol. In terms of clinical presentation and the cardiogenic shock and the cardiopulmonary arrest, pulmonary edema included more in the ACS group. These three hemodynamic collapse state included in around 40% in the ACS group. Therefore, CCS class 4 is most frequently observed in the ACS group, 68%. On the contrary, without ACS group, CCS class 1 or 2 included in more than 80%. In terms of lesion background, true bifurcation lesion is more frequently included in the ACS group, 42%, without ACS group, 30%. In terms of PCI procedure, radial access was less in the ACS group, 64% versus 74% without ACS. Imaging guidance reached to more than 97% in both groups. And notably, two-stent performance was more in the ACS group, 12% versus 7% without ACS. Sidewind dilation in one stent was less in the ACS group, 64% versus 80% without ACS. Mechanical support device using was more frequently, 40% in the ACS group, mainly by IABP. Calcium lesion modification was more frequently without ACS, 11% versus 5%. PCI success is more than 97% in both groups. This is the result. 3-year MSCE and all causes. ACS group indicated by blue line had more event compared to the non-ACS group indicated by red line. However, landmark analysis 30 days, there were no significant difference between the groups. On the contrary, all-cause death, the significant difference remained. Therefore, higher MSS rate in the group with ACS was mainly attributed to higher mortality within 30 days from the index PCI. On the contrary, there were no difference in the clinical-driven revascularization, TVR or TLR, between the groups, which indicates the efficacy of routine imaging guidance ACS with more complex lesions. We conducted a multiple analysis to identify the predictors of 3-year MACE. Interestingly, predictable 3-year MACE was varied between the groups. Without ACS group, LVEF less than 40%, rotational or orbital atherectomy using two-stent implantation had a significant impact. However, these factors did not have an impact in the ACS group. On the contrary, the male sex and mechanical circulatory support device using had significant impact. And ladder access reduced the risk in both groups. This figure indicates the 30-day mortality after PCI in LM-ACS and the penetration rate in the intracoronary imaging guidance. The previous report, intracoronary imaging, gets the 20%. However, 30-day mortality remains 10 to 25% after introduction of the penetration rate of the intracoronary imaging high rate in Japan. And this slide showed the impact of the cardiogenic shock on 30-day mortality after LM-ACS PCI. Here you can see the non-cardiogenic shock steadily, 30-day mortality steadily decreased. However, in the cardiogenic shock case, still remains higher mortality, more than 35%, regardless of imaging-guided PCI. In conclusion, of the consecutive LM-PCI cases compared between ACS versus non-ACS under routine imaging guidance, ACS patients presented with more complex lesions and higher incidence of hemodynamic collapse, yet received pretreatment for coronary risk factors. The MACE rate was higher in ACS than non-ACS patients, mainly driven by increased 30-day mortality. Despite a greater lesion complexity, routine imaging guided LM-PCI achieved similarly low rate of clinical-driven revascularization in ACS and non-ACS patients. In non-ACS patients, lesion complexity, true bifurcation lesion, severe calcification, and reduced LV function were major predictors of MACE, whereas in ACS patients, cardiogenic shock-related factors, MCS use, male sex were key determinants. Thank you for your attention.
Thank you very much. I think we conclude this session, then we have a discussion how to manage a left main and multi-vessel in-stent with stenosis, DCB, drug-eluting stents, or bypass surgery by Do-Young Kang from Assam Medical Center.
Thank you for your kind introduction. I am Dr. Do-Young Kang from Assam Medical Center. I will talk about the left main and multi-vessel ISR, how to treat. And I will concentrate more on the left main ISR. I have nothing to disclose. This is a case of the 64-year-old male that underwent distal left main bifurcation 1 year before. And initial CAG at the hospital showed the circumflex osteal disease and left proximal LA disease. And initial procedure was done with the left main to LAD stenting, and then provisional ballooning and stenting was done with the TAP technique. And then final kissing was done. And CAG after 1 year, because of the chest pain, showed that the left main stem and circumflex osteal disease recurrence. Then how do we treat? And the current evidence on left main ISR is still limited because of the small numbers of the patient that presented. And the incidence of the left main ISR was known in routine angiography follow-up era as a 15 to 20%. And the following the left main ISR registry still reported 10 to 20% after left main bifurcation PCI. And the IPD meta-analysis of the 3 left main trials also showed that the 18.3% of the lipid revascularization rate at 5 years after left main PCI. And that the timing of the left main ISR, when do it be? In our centers, the Assam left main and combined with the main compare and ILIS left main registry, that the most commonly happened after 1 year and belonging the early stages. And at the 10-year follow-up, about 11% of the patients experienced the TLR in our registry. And the clinical presentation in FAIRS registry from Italia and the AMC registry also both showed that the major of the patient has a stable angina or unstable angina. And about 3% of the patients visited the clinic for the myocardial infarction. And the angiographic presentation showed that the major is a focal ISR, and one-third of the patients showed diffuse ISR in angiography. And in our pre-combat 2 trial, it showed that even in single or two-stent technique, the most common location of the left main ISR was the ostium of the circumflex. So we can say the Achilles heel, the weak point of the left main PCI is the ostium of the circumflex. Then this patient also showed the same situation. The disease recurred in the circumflex ostium and also at the distal bifurcation. How would we treat this patient? And there is some big patient-level pooled analysis for the conventional in-stent restenosis. They compared DCB versus DS with the 10 RCT patient-level meta-analysis data-loss study. It showed the composite of hard endpoint or cause death, MI, or lesion thrombosis was compared between DS and paclitaxel-coated balloon. However, the target lesion revascularization rate was higher in the drug-coated balloon, so the guidelines recommend the 1A for the DS for the treatment of the ISR. The US and ESC guidelines also recommend 1A for the DS for the treatment of the ISR over DCB. However, for left main, what is different? If there is one previous crossover left main stent, then adding one more stent makes the 2 metal layer in the circumflex ostium, and the rewiring will be extremely difficult, and the flow to the big circumflex branch can be jailed. And in the patient with the previous left main 2 stent technique, is even more complex. Additional DS at the circumflex ostium is very technically difficult, and usually it will protrude into the left main carina. And doing the 2 stent technique once again or crossover in the left main makes the 3 or 4 metal layers at carina, and the procedure itself would be extremely complex. So the many patients underwent the balloon treatment in the previous registries. First registries, the 84% was treated with the PCI and the DS 60% and POVA 40%. AMC registry, the DS and POVA was FNF. However, in our registry, in the detailed view, the DS was mainly implanted at the previous crossover circumflex ostium, and the bifurcation itself was usually treated with the POVA, with a plain balloon or DCB. The METO registry also showed that half and half of the DS and POVA. And KBG was selected as an initial treatment in only 10% of the patient. And in ASAN, the left main registry, about 10% of the patient with the left main TLR, 3%, the 30% after the TLR, the experienced once again TLR, and the main patient, the 2/3 of the patient underwent PCI again. After that, the 3rd TLR event was very rare in only 4 patients after 3rd TLR. So the current evidence of the left main ISR, the overall MACE rate was very variable, 25% to 30%. However, the CV death rate is not so high. And our registry data shows that after left main TLR, MACE-free survival rate was 87% after 3 years, and it was similar between KBG, PCI, or even some medical treatment patient. And cardiac death MI and TLR rate was similar between DS and balloon angioplasty and DCB patient. However, the patient is has a very variable anatomy, so it's very difficult to uniformly say that all 3 has the similar outcomes. And the impact of the left main TLR on long-term clinical outcomes on mortality or cardiac death was not different between TLR patient or non-TLR patient. If we treat well, even in left main TLR, the patient survived well, and it was the ISARA left main 5-year report also showed that the patient with the RR did not show different outcome after PCI or stenting or bypass surgery after left main TLR. And my solution was a PCI using drug-coated balloon to avoid additional metal. And after the NC ballooning of the bifurcation, and then apply DCB as circumflex, and LAD again, and did the kissing with the DCB. And the main problem is that to keep the long duration at the left main ballooning and to keep the patient vital signs stable is very important for the procedure. And this is the final CAG, and the patient is doing well. And for multi-vessel ISR, the same strategy can be used as a usual ISR. However, we should consider DCB first to avoid excessive stent implantation because the multi-vessel patient already would have many stents, and DES can be implanted at favorable anatomy or recurrent ISR after DCB. And diffuse or recurrent ISR, then CABG should be considered to avoid stenting at grafting candidate area, and recurrent small fixes can delay or need a big change with the CABG. And in IRIS DCB registry from our center that showed 9% among 590 patients with the ISR treatment had a multi-vessel ISR, and 1 year TVF rate after multi-vessel ISR was 9%, 4%, and there was no death, and just 5 TVR are recorded as a second TVR, and then the patient was once again treated with the DCB or DES. And this is my conclusion. For left main, I would consider DCB as a first, and consider DES or DCB for de novo ostial circumflex disease, and careful clinical follow-up with the intensive risk factor control. And CABG can be recommended for recurrent ISR, or from our data, we would consider it after third recurrence of the left main TLR. And prevention is better than treatment, and intravascular imaging guided optimization during the index PCI could minimize ISR. Thank you for your attention.
Thank you very much. We have time for questions. I think the topics were all very important.
I'd like to ask Dr. Kang. Okay, as you mentioned in the last year, and ESS recommended the DS implantation for the DS ISR. However, and usually operators doesn't want to make the multi-layer metal. So in the left main ISR lesion, what do you think? What is the precise clinical and imaging-based criteria for choosing DCB treatment rather than DS implantation?
Actually, for left main, I 100% prefer DCB because the adding one more metal on the left main, especially at the carina, is very big burden for the patient and also for the operators. So the weapon would be the DCB, and some patient can be considered for DS implantation, especially at the patient with the downstream disease at the proximal LAD, or the patient with a crossover stent and then a recurrence of the circumflex ostium or proximal circumflex. Then I would apply the balloon first, and if the balloon response is bad, and I would consider the stent implantation. However, it also will make the very complex or dirty carina, so that is not a preferable treatment. So for left main, the guideline recommendation is not easy to apply for me.
Dr. Kang, the current guidelines do not endorse routine angiography after left main PCI.
Yes.
If there is ISR and you repeat PCI, there's a high repeat revascularization rate, higher event rate. The second time, do you recommend angiography, or you still follow them clinically and maybe do non-invasive physiologic assessment?
For my personal opinion, I would not recommend the routine angiography because in our post-PCI trial that compared routine surveillance versus just symptom-based treatment, in left main subset, the routine surveillance did not show clear benefit. And also the routine CT evaluation after the left main PCI did not show the clear clinical benefit in recent trial. So for left main, the main patient, the major patient with the recurrence visited the clinic for not for the MI, but for the increasing angina. So I would recommend the patient to check the patient's symptoms themselves very cautiously, and then I believe that we can find the patient, the recurrence based on the symptoms.
You know, I like to make a consideration regarding drug-coated balloon for ISR. You know, the study quoted of Jacobo has a lot of heterogeneity.
Yeah.
There is a mixed bag. So I'm very surprised about the recommendations of the society. My point is that if you plan to do drug-coated balloon for ISR, is a must to do IVUS before DCB and make sure that you have achieved an acceptable result. Because when you do drug-coated balloon for ISR, you cannot rely on positive remodeling. And unless you have achieved a good result, there is no advantage in limiting hyperplasia because you already leave the result with hyperplasia. So you can only use DCB if by IVUS you have achieved a good result. Otherwise you insist more and maybe you implant another stent or you do nothing. But it's really unacceptable to use a DCB if you have not achieved a good result. And I have a question also. Regarding Achilles heels of the circumflex, do you have data that support that the risk stenosis in the ostium of the circumflex is very low if you have achieved a good result at the primary stenting? I mean, is the circumflex bad because we don't do a good job at the beginning, or is bad in general?
Yes, we have published the data from the IVUS evaluation after 2-stent or the crossover stenting at the left main, and the patient with more than 200 patients underwent crush technique and more than 5-year clinical follow-up. The circumflex ostium, the minimal stent area, was the strongest predictor of the future clinical outcome, including TVR, and the lumen area more than 6.8 was the predictor of the future clinical outcome at the circumflex ostium.
Right. My question is
okay. You mentioned about the circumflex ostium is mainly hinge point of ISR and main stent procedure, right? So just think about it. We don't have any imaging concern, angiogram. We don't need an angiogram follow-up, just a clinical follow-up. There is single vessel, 70–80%. Even the patient had a positive silent scan, something like that. What do you think? We can maintain, just optimal medical treatment, something like that. The meaning is clinical TLR, TBR is totally, very subjective things sometimes, right? So after ischemia studies, it'll be further focus on the optimal medical treatment, even in the single vessel circumflex ostium, ISR. Actually, what percent of patient had a really symptomatic and need a TBR? That's another clinical issue.
I had a question for Dr. Seung-Jun Lee about. You gave some really interesting tips and tricks about using OCT for left main PCI. But my question to you was that, is there a particular advantage to using OCT for left main PCI? And I would argue the counter as, why bother? just use IVUS because it's much more easier. So could you point out any specific advantages regarding left main PCI that OCT offers that IVUS does not?
Yeah, thank you for nice question. Although I have focused the overcoming hurdles in left main PCI by OCT guidance, I absolutely agree. Still, the OCT is beneficial in distal left main bifurcation and proximal and osteal disease, and very large vessel suitable for 6 or 5 stent is IVUS may be better. However, regarding your question, recent OCT device and the next coming device has very advanced software that can visualize stent morphology and the osteal patterns with 3D reconstruction in real practice. I think in that situation, I think distal left main with complex anatomy OCT can be a good option.
Just I have one technical question to Dr. Lee. With regard to use of saline instead of contrast in OCT, okay, is it the same amount of contrast you need to use, or saline you need to use, or different?
That is an example of the advancement. It is certain that saline-based, contrast-based approach is standard, but that is another example that is merit from the new device with very fast playback speed. However, in the case we infused, as I know, 20 milliliters of saline, fully opacifying the RAD.
Is there any concern with patient with low ejection fraction to use more fluids?
Low ejection fraction?
Yeah, in patient with low EF.
Sorry.
Still use saline or how?
Saline, I couldn't.
No, I mean in your OCT imaging capturing. So for patient with low ejection fraction, so still you consider to use saline to reduce the risk of CIN or how?
Yes. In high risk patient, the patient safety is the most important issue. So I think saline injection could be considered in patients with low renal function. However, in high-risk CHIP patient with low ejection fraction, fast and safe procedure along with optimization is important. I think in high-risk patient, IVUS may be much better.
Okay, I think we can close this session. Thank you very much for all your questions and presentations, and we go to the next sections about bifurcations.